Hello. Today I'd like to talk about the role of optical coherence tomography, or OCT, for identifying vulnerable plaque, and people are now using various terms, high-risk plaque, when guiding PCI. And this has sort of fallen out of favor, but does OCT have a role for identifying vulnerable plaque and guiding PCI? Yes, we'll make a strong argument for it, but there's a lot of studies that have been done over the last 15 years that we feel have clouded this point. My name is Mark Brezinski. I'm an MD PhD. For those who don't know, I introduced cardiovascular OCT and OCT imaging in non-transparent tissue in the early 90s along with James Fujimoto. I started the program of cardiovascular OCT at Mass General and Harvard Medical School. I co-founded Light Lab Imaging along with Eric Swanson, Jim Fujimoto, and the Zeiss Corporation. Most of my adult life has been with Harvard Medical School, Mass General and/or Brigham Women's. I won the Presidential Award for OCT work from President Clinton in 1998. I've authored over 150 papers. I wrote the textbook of optical coherence tomography and didn't write only 2 chapters in it. I wrote from everything from the physics to the engineering to the clinical problems. 2 of the chapters I didn't write, one were Doppler, but I didn't write clinical trials because of being a clinician and even being a formally trained PhD, having worked with multiple Nobel laureates. That doesn't make me a clinical scientist, and a lack of clinical scientists I will bring up has been a problem in the OCT field. In 2000, I formally moved to the orthopedics department at Brigham and Women's Harvard Medical School. At that point, we were moving into clinical trials, and I thought it would go straight forward into patient management and regret decision, having moved out of cardiology for the most part. At that point, I continued to publish papers, but not to the same degree I did prior to 2000. So with respect to vulnerable plaque, does it identify thin intimal walls? Well, for TCFA, thin cap fibroatheromas, you need to identify walls less than 80 to 100 microns in thickness. And yes, I think the evidence is very strong. The consensus study outlines the data behind that. And so this is an area where OCT is very strong. With respect to necrotic core, I include this as an unmet need. First, the literature is very confused with papers published. When you actually look at them, they're looking at lipid core, not necrotic core, and it's very different. Lipid core is lipid. Necrotic core has red cell membranes, angiogenesis, some degree of inflammatory cells, other kinds of cellular debris, a lot of free cholesterol. And we don't believe that the diffuse border criteria that's currently being used identifies it. I mean, we believe it's stronger just qualitatively looking at the image is a more effective approach, something that as a clinician you're used to doing, but for people who work with numbers, who want a quantitative approach like diffuse borders or specifically exponential decay, often don't appreciate that. Macrophages, we've made arguments since, I believe, 2005 that OCT in the highly scattering environment of plaque, particularly around all the cholesterol crystals, doesn't measure macrophages, and don't necessarily think that there's a need for it to measure macrophages. It may measure macrophages, for instance, in synovium of rheumatoid arthritis joints where you don't have cholesterol crystals and calcium deposits like you do in plaque. But in plaque, the current approaches we just don't feel work, and we'll talk about that. Does it identify plaques that are going to progress to ACS? Well, in 2014, we identified a mechanism of necrotic shafts, which we'll discuss, where TCFA is in proximity to long necrotic shafts that contain thrombotic material, huge amounts, are the ones most likely, or they're our greatest suspect for causing ACS. And one of the problems we feel has been we try to always work with somebody who's a true clinical scientist and have outcome related research. The endpoint will be, if the hypothesis is tested positively, that it will change patient management. And there hasn't been a lot of that in cardiology. And so even like I said, working with Nobel laureates and being formally trained as a PhD doesn't make you a clinical scientist. If you go on my LinkedIn page, my greatest skill is listed as clinical trials, and I didn't even write the own chapter in my own book because I don't feel skilled enough to do it. These figures come from, I believe, this paper, but it shows from the consensus trial. The left is intimal hyperplasia. Cardiologist is going to know what that is. The middle is a xanthoma. These are lipid plaques, lipid collections, lipid crest. That's very different to the right, which is a necrotic core, which has a high amount of debris inside the core. And we believe you can actually image this structure. If not, there's other techniques that have a role, such as elastography. But the diffuse border criteria, we're going to say it doesn't work. And this is from the consensus study I was not a part of in 2012. At present, there are no definitive published studies directly comparing OCT lipid pool containing plaques with necrotic core by histology. And as a result, the evidence level was determined to be low for OCT delineation of necrotic core. And that, I believe, is absolutely true when you're using diffuse borders as exponential decay as your criteria. Now, this was republished in 2014 by our group, but it was from a 1996 circulation paper, and from our group also. If we first look at the histology on the bottom, we see a necrotic core with intima above it. It's greater than 100 microns, but it makes the point. And so it's necrotic all the way through. It has debris in it. But if we look at the OCT image on the top, the yellow arrow has diffuse borders. If we look at the intima above it, it's highly scattering. That's what those bright dots are. And we see in the histology, there's cholesterol clefts. On the right, we don't see a lot of cholesterol clefts in the histology, and the borders are sharp. So this is a necrotic plaque which has diffuse borders on the left, doesn't have diffuse borders on the right. And it's hard to say, and we've presented other evidence like this, that this diffuse border or exponential decay criteria is identifying necrotic core. I think it's more likely that necrotic plaques just have a tendency to have more lipid crests and calcium collections in it. Now, this is from our group also. And you look at these necrotic, this plaque on the left by OCT, and you can see structure within the necrotic core by the red arrow. And as cardiologists, we are used to seeing things qualitatively. We rarely use quantitative data, and the histology confirms that it has that there's a necrotic core present. And again, we're looking at plaques, necrotic core. We see structure. This is not exponential decay in the fact that exponential decay means that from the surface it's decaying at an exponential rate. We see a sharp border, and then we see structure within the plaque. That's random collections. This would not be from multiple scattering from the intima like we saw in that one original image in the previous slides. This is from actual structure within the necrotic core. And so we does OCT identify TCFAs that progress to ACS? We think we've identified a mechanism. This is based on a case and also histology from our group, where in the one case, a stent broke a TCFA at its edge, and it fractured into a long necrotic core, or shaft, as we call them. The shaft ended up evacuating its massive amount of thrombogenic material distally, leading to a clot formation. And that can be seen on the video. You can go to the original paper. But if you look distally, there was a TCFA in the OCT images that was not near a necrotic core. And so that plaque didn't lead to clot. That TCFA rupture didn't lead to clot formation. So the term shaft is to differentiate it from just a big collection of necrotic material. So we also have a video that demonstrates the principle. I mean, blood flow, ruptures, goes into the shaft. Actually, incidentally, this was seen at Geisinger Hospital, and the concept of a shaft came as I passed over the Knox mining disaster, where they came in the mine came in close proximation to the river, and the river ruptured into the mines. And so it's a very similar effect to what we're proposing is the cause of ACS in the coronary artery. And I'm not going to go through these individual slides. They're described in detail in other presentations and in the paper. Does OCT currently measure macrophages? The NSD is a very simple image processing technique that was used in the original studies, and these are example papers published by us. There's an abstract published by the Phillips group, and later they published a paper on the topic where they felt the correlation was weak. So what's getting worse in the field is that you've gone from a paper that said that the standard deviation, the normalized standard deviation, gave you macrophages in the intima. And we questioned that. But people are now more and more in the literature saying that these macrophages are actually causing shadowing in the image. And if you understand optics, that's pretty inconceivable that that's the case. And so this whole area of OCT in plaque measuring macrophages needs to be re-examined. But even going back to what the original data was, it was that an image processing technique, normalized standard deviation, could identify macrophages. So where did this concept that shadowing is a sign that there's macrophages come from? So there needs to be more histopathological comparisons done between TCFAs, and histopathology. In the stent field, there's been a few papers published, and stents have now a low rate of problems at the stent. But there's been several papers that have suggested if you place a stent on a TCFA, particularly when there's a large necrotic burden, that you can get no reflow phenomenon or side branch occlusion. And this is an area that really needs to be looked at because for the interventionalist, you know that that patient population may have a poorer prognosis. An OCT guide wire was something we worked on very early on. It would dramatically change people's acceptance of OCT, but it hasn't, to my knowledge, been aggressively pursued. But the optical fiber with OCT is less than 130 microns in diameter. It should be able, it's not like an IVUS catheter. It should be not easily, but a guide wire should be capable of being produced. Now, I recognize that there's the blood issue, and people have worked on flushing to avoid the blood problem, but if it shows, if OCT is demonstrated to be effective, we demonstrated with earlier papers by injecting high refractive index compounds, you make red blood cells invisible to OCT at 1300 nanometers. So this would be pushed forward if the applications actually exist. Same thing with the OCT guide wire. So this is just going to go on to a general point. A lot of the field has been slowed down by the concept more quantitative data is needed, more precision. And for people who work in medicine, we use a Bayesian type thinking. We have to integrate a lot of different data. We're used to mild, moderate, severe. We're used to reading a chest x-ray. We don't need densitometry of a chest x-ray. We look at EKGs. We don't need to analyze necessarily every individual segment. And I use the analogy as what's a better device for an object at a distance, a Doppler gun or pair of binoculars. Well, if you're asking the question, if there's a tiger 400 yards away and your only question is that tiger charging you or not, I would rather have the binoculars. The chances of errors with the more sophisticated technique is vastly higher. And I'm going to be running to my car if I see that tiger charging. And that's the kind of decisions you make as a clinician. Is it a TCFA or not? And so, particularly in the area of polarization sensitive OCT, we've used it in the joint on cartilage, where the orthopedic surgeons are very happy with the qualitative data, mild, moderate, severe. And the push to have quantitative data, if you're going to push for these complex systems that have a high amount of error, there has to be a reason for it. And you have to say what the unmet need is. Why do you need the exact polarization vector to make the diagnosis, to manage your patients differently? And I've never had anybody actually answer that question. This just shows another example, and if people who play golf know it, I mean the 50-yard marker in this golf course has probably been there for at least 50 years. But then you use a radar gun or optics-based distance measurement, and it says 65 yards, and which are you going to believe? So we need more clinical trials actually done by clinical scientists. We need more comparison with histology. We don't need things to be more elegant and complex, and we've got to get a lot of the misinformation out of the OCT field. And I'd like to thank the fund. I've been heavily funded through the years by Heart, Lung, and Blood, NIBIB and the NIEMS, and I would like to thank them for all my support through the years. Thank you very much.